Hello everyone, good afternoon. This is really weird. I feel like I'm just talking to Anne here. It's very bizarre when you can't see or hear everybody. So I'm hoping you're all on the other side. Welcome to the ECD, the Environment Cleaning and Decontamination first webinar. It's really exciting to be able to present something to you in between conferences, and we're hoping that we'll make a regular feature of this. You will be able to ask questions and answers of Anne after she's finished her presentation. So just use the question and answer box, please. Thank you very much to Sodexo and Necessity and Talk for helping us put this presentation on. We're delighted to have them as our corporate partners for this event. May I present to you Dr. Anne Woolridge, who told us yesterday she's had 20 years in healthcare waste. I mean, that's just phenomenal. So I don't think there's anything Anne doesn't know about healthcare waste. She has 20 years of experience of research and practical experience of healthcare waste. She's the scientific advisor on waste for UKHSA. She's technical input into waste on MERS, monkeypox, SARS, you name it, she's done it, I think. We were very lucky to have a sneak preview of the presentation yesterday afternoon, and I think we're in for some very interesting facts and some scary facts. So thank you, Anne. I'll hand over to you.
Thank you very much, and thank you very much for inviting me to speak today. It will be a whistle-stop tour of waste. There are a number of aspects to this, but I'm really going to focus on some of the numbers. I'm going to focus on the UK predominantly, although it's a global issue. So what am I going to cover? I'm going to have a quick, what are we going to do? We're going to look at legislation and why we have to do things. We're going to look at segregation, why we have to segregate waste. We don't do it through choice. We don't say, oh, well, you know, it's how complicated can I make it? We do it because it's a legal obligation, and we'll come on to that. Documentation. Because one of the things as a waste producer, you'll be putting the stuff in the bins, you'll be advising people to put the stuff in the bins. But this has to be documented, it has to be accurately described and a raft of other pieces of requirements. But the documentation is something you probably never see. But every single piece of waste, at least any of your sites, will go with a accompanying stream of documentation. I'm going to look at auditing, in addition to the IPS audits that you already do, and then I'll do a quick summary. My plan is to ideally speak for about 40 minutes on this, and then hopefully take some Q&A and open this up to a bit of discussion, because I am sure I will be raising some bones of contention. So don't worry, that's absolutely fine. So let's put this in context. Why am I even here? Why is healthcare waste so important to me? Why did I go back to university to say, I want to do something with healthcare waste? I want to stop massive amounts of waste that are going to, they weren't even going to energy from waste then, but they were either going to hazardous waste or landfill. But why do I want to do it? Putting this in context, I've only got figures for England, and apologies for those people that are from the devolved administrations. I do cover some of your legislation as well, but just looking at the figures for England, the budget for 22-23 was 180 billion, 200 million pounds. That is a lot of money of anybody's, 1.5 million employees within the NHS who should all be trained to correctly manage their waste. The NHS is 24/7, 365 days a year for decade upon decade. So we never stop producing waste. Just want to divert slightly, because this is one of my areas of research as well. But primary care prescriptions last year cost £8.5 billion. Previous to that, in 2021, they cost £9.2 billion. So we brought those costs down by about £700,000. But sorry, £7 million. But we spend £8.5 billion on pharmaceuticals, but we know that somewhere between 10 and 30% of those pharmaceuticals are never used. And this is just primary care. This isn't your hospital stuff. This is just primary care. So we're wasting about £3 billion worth of pharmaceuticals per annum. That is waste on the 200 pounds per kilo in terms of waste. So we're spending a couple of millions getting rid of it as well. But in terms of value of what's going in that waste stream, it's about £3 billion. Bringing that to waste, the NHS in England spends somewhere around 151 million, not billion, we're now in the million, 151, 156 million disposing of waste. The 156 million pounds includes all the wee waste, the electronics and some of the lab equipment. But I'm more looking at the stuff that goes out on a daily basis rather than at. This comes to 0.084, so 0.084 of the NHS's overall budget. So less than 0.1%. Now you can see why we cannot get this easily onto the chief exec's desk. Because if it's even if you take this as primary care, but you look at the prescription, the prescribing costs, the carbon associated with prescribing, the sustainability aspect, the transport, everything else in pharmaceuticals, that's where your big hits are. So waste is actually a really hard to pick fruit. It's not one of these nice low hanging fruits. It's really hard to pick. Everybody does want to save money. The NHS waste strategy is being released next week. And I think they're going to be looking about saving £11 million per annum for the next 10 years. But 11 million in our 180 billion is really, it's got to be done and it's the right thing to do. But to get that into context makes it really challenging. We do want to save money, but we also need to make sure that waste is managed well. And it costs money and it will probably cost investment as well. These are current figures. These are off the last year's ERIC returns. So we're recycling and they're average across the country. Some will be paying more, some will be paying less. But recycling is about £106 a tonne. So it's not free. You can't give it away. Sometimes you get a rebate. You can't always. Domestic waste, if it's going to landfill, about 328. A lot of that is actually tax. Energy from waste doesn't get the tax, so it's a reduced price. Offensive waste, our tiger bag, going to talk a lot more about that in a bit. That's about 336, whereas our honest clinical waste bag is about 380. Sharps waste is about 800 a tonne, can be up to 14, can be down to 6, but you can see that we have a differential here on pricing. But even if you add it all up for everything that's generated, we're still only spending, say only, but it's £156 million. So back to the beginning. What is waste? It is any substance or object the holder discards, so thrown away, intends to discard, so you can't keep it for later, or is required to discard because it's out of date or unusable. So this is defined in law. So we have a legal definition of what waste is. So there's no doubt, oh, is it waste? Is it not waste? Can I use it? If I can't use it, it's waste. This is where we sit at an international level, the World Health Organization. We align all our guidance in the UK with the WHO stuff as well. But healthcare waste includes anything that is generated within healthcare facilities, research centres, laboratories. So anything that's related to medical procedures, not necessarily in that health environment, but can also be produced from other places. And note the words, I am using healthcare waste here. I have not used the word clinical waste yet. I will be. So what's clinical waste? It is very specific, and in UK law, subtly different in Scotland and Northern Ireland, because Scotland and Northern Ireland use a different definition of clinical waste, because theirs had blood and body fluid contaminated, whereas it's different in England and Wales. But wherever you are, it's going to be infectious waste. It's going to be anatomical and pathological waste, depends where you are to what you call it. It's going to be pharmaceutical waste. It's going to be sharps. So the Controlled Waste Regulations of 2012 define clinical waste as that waste that's infectious, pharmaceutically or chemically contaminated, or sharp. So we've got that nice legal definition that sits within UK law. As I say, slightly different for Northern Ireland and Scotland, because you use the 1992 definition of infectious waste and clinical waste, and we use the one out of the hazardous waste regulations, and also the one out of control wastes and little piece of documentation. We have other wastes that are non-hazardous. We have our offensive waste, which does have body fluid secretions and excretions, but not from known infectious cases. Or known, the waste is known to have infection on it. We have municipal waste and recycling waste. So no hazardous properties, no sharps risks, no chemical, no pharmaceutical. So that again is a big section of our waste, and it should be our biggest proportion. We also have electrical waste, chemical waste, and radioactives, but I'm not going to focus on those today. Why do we even do this? We work globally, we work as part of humanity in overarching principles. One of the overarching principles that we have is we should take precautions against any possible damage to the environment or any living thing. So that's the precautionary principle. But the precautionary principle, which is where I get it quoted back at me, is not putting it in the wrong overclassified bin in case it ends up in the wrong place. Precautionary is making sure we don't damage the environment, and that means correctly segregating and classifying our waste. We have polluter pays and extended producer responsibility. So we should make sure that those people that are producing the items, as well as those that are disposing of them, are doing so in a responsible manner. And this is where I'd like to start seeing companies looking at take back schemes, where I'm working with companies to take back diabetic, I'm going to say paraphernalia, that sounds awful, but you know what I mean, like application for sensors and insulin pens and things like that, asthma inhalers. You know, we have millions of these things on the market. Can we find a better way for taking these back? If I was in France, I'd have absolutely no problem, because if a producer supplies something to a householder, pharmaceutical, they have to take it back. They pay for it to be taken back and they take it back. It's called the DASTRI system. Proximity and self-sufficiency. We should be working, disposing of our waste as close to the point of generation as possible. And I don't mean put a bin by your left hand, I mean like within your geographical region. And we have our duty of care. And this is the fundamental tenet of good healthcare waste management. You have a duty to ensure your safety, the safety of others, handing over waste to appropriately licensed, permitted, registered individual, to registered waste carriers. But our duty of care extends beyond just our immediate vicinity. It's for everybody in the waste chain, including those that make the environment. Sustainable development goals. And I'm sure there'll be some discussion about this as well. But the Sustainable Development Goals apply to everybody. They're a United Nations construct. Everything we should do should be aligned with these Sustainable Development Goals. And waste management really helps with good health and well-being, clean water and sanitation, decent work and economic growth. Not going to go into modern slavery, but one of the biggest sectors in the UK that has had problems with modern slavery has been the waste sector. Not necessarily clinical or those specialist contractors, but it is certainly something that they're very aware of. There's a lot of work being done. Responsible consumption and production. Do I really need to use that? Could I have it made differently? And climate action. Several NHS trusts, and I don't know whether across the UK, have declared climate emergencies. We're in a climate emergency, and healthcare waste is not always helping, or healthcare is not helping with the waste that's being produced. So, whistle stop tour of legislation. We have our waste duty of care, cradle to grave. We have our hazardous waste legislation, 2005 as amended. Scotland, you've got the special waste regulations, which will incorporate hazardous as well. Environmental and permitting legislation. These define how waste is moved, treated. They say how the people that are treating the waste test it. Do we test for emissions to water, air, land? So this is the matter for the waste contractors. They deal with this part. But you've got to make sure that the people you're sending your waste to are permitted to do so. Health and safety legislation. So we have COSH, we have lifted equipment, we have manual handling. So there's all that health and safety equipment as well. Noise, for instance, if you're working in a noisy waste environment. We also have the carriage of dangerous goods and use of transportable pressure equipment regulations, which are how we move our wastes in the UK, which is why we use the biohazards and things like that. I'll show you that in a minute. So we have ADR, which is it used to be the international agreement on the movement of dangerous. Sorry, it used to be the European, and in 2021 it became international because 51 member states of the United Nations have signed up to this. So I know I'm talking to the IPS as, we're sort of big, I'm going to be UK centric, but this is a global construct to keep people safe. Infectious clinical waste is classed as dangerous goods. due to its infection risk. So we have to have an infection risk for it to be a dangerous good. Key point there. We have legislation that says this is how you pack it, this is how you mark it, this is how you label it, and this is the documentation that's required. And this is just, it's not recommended any product by any way, shape or form. I just like it because it's got most of the colours on it. We have UN 3291, clinical waste, unspecified, not otherwise specified. And you might go, well, that's a bit of a daft thing. But it is. It's what it is, because regardless, and I'm sure as IPC professionals, you're working in completely different areas. So if somebody's got to focus on, I don't know, maternity and pediatrics, they're going to have a completely different bag composition than those that are working in elderly care. And then suddenly I'm in general medicine and I've got loads of pharmaceuticals with no surgical drains. I go into general surgery. So I've always got a different composition. And even if I'm running a flu clinic or you're running a flu clinic, every single bill will not be the same. But if I'm putting 5 litres of petrol or 5 litres of xylene or 5 litres of phenol, I know its chemical composition, I know it's how it's going to behave. Clinical waste isn't the same as that because it's going to have that wider variation. We have packaging instructions, so we have P621, which is the packages that you see on a daily basis. We have LP621 or IB620. So even those big yellow carts that you see outside are tested to a standard. Environment and waste legislation, we must. And you will see this in the CQC documentation as well. They put it in a different order. I don't quite know why, but they did. So we must correctly classify it. What is it? Is it a pharmaceutically contaminated syringe and needle? Is it a Coke can? Is it a bit of packaging? Is it a tray? What is it? Once I've classified it, I can segregate it. When I've segregated it, I need to store it because somebody doesn't come and take every single piece away. I must then make sure it's stored correctly, disposed of with the correct documentation. It doesn't matter where you are in the world. If I took out the images and the bit under these are the requirements of the NHS, EA, CEPA, NRW, and NIEA, which are the relevant regulators, I can present that slide anywhere in the world and it still applies. This is a European construct, although it should be a global. It's written in, it's enshrined in all of the UK. So this is the waste hierarchy. The last thing we want to do is dispose of stuff. The first thing we want to do is not generate it in the first place. But I'm a realist. We're here. We are generating waste. So what we have to do is make sure that we treat it, dispose of it safely, cost effectively, and in a manner that doesn't negatively affect the environment. Now, if I had my way, I would go safely, in a manner that doesn't negatively affect the environment, and then I put cost effective at the back, because if you do the first bits right, you're going to reduce your costs anyway. This is the DEFRA diagram. The reason I like this diagram is it shows that there are residues. It doesn't show that the system is perfect. If I present this in 5 years' time, maybe even 3 years' time, I will not have a waste hierarchy. I will be doing this in terms of circular economy. What I can say, though, is all those pillars of legislation, and this is out of HTML 701, the 2013 version, and it was also in the 2006 and 2010. But we have health and safety and infection control legislation. We have environment and waste, and we have transport legislation, and collectively they give you good healthcare waste management. They don't always agree. We sometimes get a bit of a variety, we get a bit of difference between health and safety and infection control and the environment and waste. And I am going to try and unpick that a little bit as we go through. We have official guidance. I'm sure many of you are aware, but if not, welcome to the new brave new world. And next Wednesday, the NHS England Clinical Waste Strategy is released at 10 AM. And at what it was 2 o'clock, it's now 1 o'clock. HMO 701 Safe Management of Healthcare Waste is going to be released. If you want an absolutely pre-seed version of how to segregate waste, the NHS COVID Waste Management Standard Operating Procedure version 6 is basically HTM cut down into very few pages. The NHS in England is the first health system that I've worked with, and I work, as some of you know, quite extensively, It has said we've embedded net zero carbon into legislation. You have beaten the government targets of 2050. It has said the split will be 60% offensive waste, we'll come on to that in a minute, 20% infectious waste and 20% incineration only waste. What we need to do is even better by not generating a lot of waste in the first place. We have had a lot of single-use items. This is a PPE slide. This is recent data, by the way. I should point out I've done a lot of research to try and get you the most current data for this presentation. 2019, so pre-pandemic, and that is me and my kit, bag splitting in the pandemic. 20 risk assessed, obviously. We normally do about 2.3 billion pieces of PPE. Now, this is stuff that was supplied. This is not the stuff that was bought. This is the stuff that has been pushed. So I must stress that more than this has been bought and used by NHS and adult social care. This is the stuff that has been pushed by the DHSE. So we use 25.2 billion pieces of PPE, 17 billion gloves, nearly 3 billion aprons, nearly 4 billion type 2R masks, only 30 million type 2 because we don't really like those. 155 million FFP3s, 173 million pieces of eye protection, as well as 105, just under 106 clinical waste bags. Now, those are the ones that are pushed, and that is in addition to probably the 142 million clinical waste bags we use on a normal year. Those figures are staggering. The photograph on the bottom right is actually the beautiful statue outside the Royal Free Hospital, where, ironically enough, HPM and the strategy are going to be launched next week. But I took this in the middle of the pandemic when somebody kindly put on my phone. The NHS used to pre-pandemic, even right up to January 2020, we reduced about 213, 220, 230 on a bad day. Tons of clinical waste a day. And by that, I mean stuff that absolutely needs treating. At the peak of the second wave, we were producing 630 tons of clinical waste. And you can see from the numbers here, the majority of that was single-use PPE. And it wasn't all from COVID wards, it wasn't all from COVID areas, it was PPE in general practice. So I was in the hospital Monday auditing, I had to wear a mask. Waste classification, I'm not going to spend too long on this because I am conscious that, you know, we really want a discussion, but the way the regulations are set up, we have hazard properties and we have 15 of them. And I'm not going to go through the detail other than to say HP9 is the coolest because that's the infectious one. We have potential properties, other hazardous properties. So we may have something that is carcinogenic and infectious. We may have something that's flammable and infectious. We may have something that's toxic and infectious. We may have something that's corrosive. So infection is covered under our dangerous goods regulations, but we'll have all these other types of hazard. What we won't see in waste is those other hazards presented, because these hazards you see, the globally harmonized system of labeling is for waste that are for supply. Sorry, there are for items for supply. We tend to just see the biohazard. So the only way we can communicate that on the documentation is through other communication and people saying, what do I need to render safe? We must work with infectious waste, sharps waste. Anatomical doesn't really require rendering safe, but we do have cultural norms here that say we don't just send it anywhere. It does tend to go to incineration under the Human Tissue Act. We have pharmaceutical waste and cytotoxic waste. We have radioactives, obviously, and lab waste, which is culture specimens and chemically contaminated. So we must do something specific with those. This is where it starts to get a little bit more contentious, because from a waste management perspective, not from a clinical perspective, not from an IPC perspective, from a pure waste management perspective, to be infectious waste, it must be substances or preparations containing viable microorganisms or their toxins, which are known to be, I've not got back to this, but it's substances that contain viable microorganisms or their toxins. So in effect, I'm saying from a clinical perspective, well, you are going to treat me as IPC and as any clinician with standard and universal precautions going, right, I don't know you. I really don't know you. far as I'm concerned, you're a teeming reservoir of bugs. So I'm going to treat you as though you've got everything. From a waste management perspective, I can't do that. I have to assume you haven't got anything until I know you have. And that's where the dichotomy is. That's where we've got to make sure that clinically everybody's treated as though, you're protected, both the patient from you and you from the patient. But from a waste management perspective, we have to very much go and say, is that waste likely to be infectious? Under ADR, we have two categories, and I'm not going to spend any time on this other than to say your category A's are your Ebolas, your Lassa fevers, things like that, your viral hemorrhagics, and pretty much everything else is everything else. I will say clearly that there is a broad alignment, but not a definite alignment between your hazard group 3 and hazard group 4 and your CL3, CL4 and your Cat A's, but it's not a straight line. You can't go, it's a high consequence infectious disease, therefore it's a Cat A. It doesn't work like that. But we do have a list. The reason I've put some of these slides in is because you will be able to refer to these later should you need them. You will also notice this is still called monkeypox virus in this particular document because this has come through the United Nations. It will probably take 4 to 6 years, maybe even 7 years to get the MPOX changed in the publication because it has to go through a range of committees, decision makers. But it's been derogated till 2025. Big. So once you've assessed your waste, what happens to it? We can either incinerate it, we can send it to an alternative technology, or we can send it to landfill or energy recovery. And the way we do this is by colour coding. So if you think national curriculum for waste, if we say something is yellow, you put it in a yellow bag, not a tiger bag, but a yellow bag, yellow hard burn bin, yellow lidded sharps bin, it will be sent to incineration or a suitably licensed or permitted facility. Because we've now got about 3 in the UK that can take these and alternatively treat them on a closed loop system. So they are not all incinerated. We have our anatomical waste, which again goes to incineration. We have our alternative treatment waste, which is most likely to go to an industrial size autoclave, rotoclave, something like that, but it is rendered safe. It is disinfected. It is not sterilized. It is waste. It is not sterilized. It's disinfected, rendered safe, decontaminated, whatever you want to call it, but it brings it to a point where it can then be treated as a non-hazardous waste. We have our cytotoxic and cytostatic wastes, which can only go to facilities that are permitted. Burn those. They will be drip fed in very low quantities, for instance, or they'll be retained at a higher retention time. There's a range of ways that these are treated. We have our medicinal waste for incineration. This is the blue bins you've seen appearing since 2010. Those can go for incineration, they're non-hazardous, so they tend to go to energy from waste facilities rather than your big hazardous incinerators. Our offensive waste and hygiene, it goes to landfill or energy from waste, and it shouldn't be compacted on site unless your Environment Agency knows, but we're getting a little bit more flexible about that now. And then we have our domestic type waste, our recyclables and our black bag in inverted commas waste. So again, not all the waste that has come in contact with a patient is infectious waste. We have specific requirements for our infectious waste. And this photograph on the right hand side for me is a classic environment of somebody going, I know it's not that infectious because I haven't actually bothered to even tie the bag up. I've put it in an infectious bag, but well, it's okay. It's not okay. Because if you're saying it's infectious waste and we segregate properly, that waste should actually be really, really quite hazardous. So that's where we've got to start thinking. We've got to say, if it's infectious waste, it is a hazardous waste. If it's non-infectious waste, it's non-hazardous. And that should be our highest volume. This is our offensive waste. It is legally defined as that waste contaminated non-infectious body fluid secretions and excretions. So sorry, Scotland and Northern Ireland, but ours does contain blood and it does contain gel body fluids. I know that yours doesn't. It is not sharps, anatomical, chemicals, medicines, dental amalgam, or anything that's infectious. But this is what the NHS England want to see 60% of the waste that is actually contaminated, not 60% of all the waste, but just the 60% of that waste contaminated to be going out on this stream. Sharps bins. I've only left it in because they need to be of a specific standard. So in addition to the AGR requirements, we must also meet ISO 23907 2019 standard. There is, for those of you that are interested, a standard for reusables now as well, and that's 23907 2019, and they must be used correctly. The photograph on the right-hand side is mine. In fact, all the photographs you see are mine. The photograph is mine, and this was a department that decided it was quicker to fill the bin and then put the lid on when you're finished. I think the duty of care went out of the window on that day. Poor segregation does cost money, it costs the environment. So this, you know, you saw me in my full Tyvek and my respirator, and I didn't have my face thing on at the time, but I was fully protected. So this is cardboard boxes, outer packaging cardboard boxes in orange bags. The middle photograph is from a mess room, and then on the right hand side I've got all sorts of non-hazardous wastes being put into the orange infectious waste stream in the middle of COVID. So you go, well, actually they just put it straight in the bag. This is where it starts to get a little bit worse. I've got offensive waste bags, so our non-infectious waste, our tiger bag waste, body fluid secretions, excretions. I've segregated it nicely, but I'm a bit scared now. I'm going to do what I think is the precautionary principle. So I'm going to put it all in the infectious waste stream. So somebody's gone to all that effort, and now it's gone out as an infectious waste, even though we know it's not. That's a little bit worse. I've now segregated all my hand washing paper towels out the bathroom. I've got clean glove boxes. I've got a load of stuff. But I'm still a bit scared. So I'm going to put it all in my infectious waste stream just in case. Gets even worse. I've got this stuff in my hospital. I didn't hang my curtains because I didn't really get round to it, or I didn't need to. So these are undated and unhung, these curtains, by the way. I've got a load of new stuff now, but I'm a bit nervous, so I'll put it all in the infectious waste stream. And we're still recovering from this. When I was first going into hospitals early in the day, I have got photographs, and I didn't dare put some of them up, but I've got photographs of crates of oranges, crates of donated food put out in the infectious clinical waste stream. It's been tough. Record keeping and documentation. We expect, in addition to the audits that IPC will be doing for a range of reasons, whether that's labels on sharp spoons, whether that's fill lines, whether that's cleanliness, whether that's segregation, there is a requirement on behalf of the Environment Agency to do pre-acceptance audits. We usually do a third of the site every year if you do over 5 tonnes, which is most large producers. They go to the warden department and they detail every single type of waste that's used in that department, how it's discarded, how it's segregated. That then goes to the waste contractor. But it needs to be written, ready to be read by the Environment Agency, because the Environment Agency read those audits and say, are you mixing waste? Do you have hazardous and non-hazardous waste mixed? Do you have clean packaging in your infectious waste stream? If so, need to make some changes because you're breaking the law. So missegregation of waste is actually illegal. We do dangerous goods audits. Again, they're a legal requirement, statutory appointment for a DGSA for a producer that puts like more than 6 or 7 parts on the road in a single go, the yellow summer, or has any nuclear med or Cat A, but we won't by that. So a dangerous goods audit is required that again looks at the packing classification. It requires that that waste has an infection potential, otherwise it's not dangerous goods. Again, another opportunity for misclassification. And this is where the precautionary principle we have to be very careful with. We need to document that waste, what is in it. So your waste managers on your sites, or somebody maybe in your central services, if you're in the primary care sector, or dental, or even veterinary. I don't know whether you've got I don't know whether you go into animal care, but it must still be documented for the waste collector. Because if you think of the package, you think of the bin, the sharp bin, the bag, that is a communication device for the waste collectors. It's also a communication device for the people collecting the waste, taking it from you, and the people that are going to treat it. Because by the time it hits a tipping floor for an offensive waste, or it hits the hopper, which is clear, by the way, so you can see exactly what's coming through. By the time it hits that hopper, you've not got any time to split the bag. So it's the documentation should accurately describe the waste that's sent. The Site registers are held by centre coordinators, and they need to be made available for inspection by regulatory bodies. So that'll be either the Office of Nuclear Regulation if it's radioactive, the Health and Safety Executive if it's dangerous goods or a DGSA report, or the police often ask for them as well, and the Environment Agency for England and Wales, and you're starting to get your SEPA are now requiring them. I'm not sure of the situation with Northern Ireland, but I know that the stuff that comes from Northern Ireland to England to be incinerated is required to be accompanied by those audits. So we have non-hazardous waste, which move on the waste transfer note, and we have hazardous moves on the consignment note. And it's a minor point of detail, but we transfer non-hazardous waste and we consign hazardous waste. So if somebody says they're consigning offensive waste, that's a bit of a, you can't really do that. They're mutually exclusive. So hazardous consignment, non-hazardous transfer. So is the focus wrong? And this is the question to you, and this is where I want to open the debate. We've procured many more single-use items. We've used a lot. There's still a lot that haven't been used. Rather than reduce, should we be striving to not use some things or reuse? I know that there's a massive Gloves Are Off campaign down from Great Ormond Street. I know the Royal College of Nursing is again behind the overuse of gloves. Interestingly, my PhD, which is like God knows how long, I did a load of work on the overuse of gloves. It didn't end up in the thesis itself, it ended up in a separate paper. But even back in like 2005, 6, 7, I was looking at overuse of gloves and reckoning that you could save 25% of some of the waste bills just by making sure people wash their hands. Do I need it? Another example I have from a real case is I went into an operating theatre. So I've done a lot of work sitting there in my scribs just watching like non-moving furniture, watching the bins, watching the stuff in the bins. And some of the scarier surgeons, if people don't know who's coming in, they'll lay a gown out of each size and then they'll pick the one and the other two go in the bin. At times drapes are unpacked but never used. So operating theatres are starting to pick it up, but I think we need to go, do I need to open this? Do I actually need this? And I'm not compromising clinical care in any way, shape or form, but I do think we have to actually look at what we're using. Is there an alternative? Can we reuse something? Can we put other stuff through CSSD? Can we get those slightly more expensive scissors that get? Or, you know, there's times we can, there's times we can't. Limit the use of single-use plastics. Well, Taxman's already done that for us, hasn't he, really? Because as from last April, to £200 a tonne, if you've not got 30% recycling in there. Single debate about biodegradable. I'm not even going to go there. But again, it's a dialogue that needs to be had, but not in the hour that we've got today. Good segregation. It is vital to correctly segregate your waste, and it is a legal requirement. It is not optional to check all your packaging in the clinical waste stream unless it's heavily contaminated with the infectious substance that could cause infection. When you do segregate correctly, it does mean that each stream is going to be treated appropriately. So your tiger bag go to a lower carbon intensive treatment than maybe a yellow-lidded shark's bin or cytos or chemically contaminated or pharmaceutically contaminated other wastes. It means your orange bag, which will just have infectious waste in, will go and get treated at an infectious waste plant, as it should be. It is a waste of taxpayers' money and resource to overpackage and overtreat waste. We know that. And we suffered very badly from it in the middle of the pandemic. Packaging and clean waste should be diverted from streams that need treatment. There is no reason, unless there isn't a bin present, in which case we need to get a bin, to put packaging and clean waste in our treatment stream. But we see it all the time. I have got, I'm going to say about 18, it might be about 20,000 photographs of clinical waste bins. And when people say, can you show me good practice? I probably have to go 6,000 or 7,000 photos back to get one. I don't have that many photographs of good practice, which is really sad. So to summarise, I know single-use plastics are heavily used in healthcare for infection control purposes, and I'm not undermining that in any way, shape or form, but I do think we need to think about it. Many can't be cleaned and reused. We can't clean tips from labs, gloves, catheters, colostomy bags, sample containers. I get that. but there are other things that could be reused. I know the PPE cell's been looking at reusable masks. It's been looking at launderable gowns. We've been looking at different hoods. So that we should continue that. There are options for reusable options for sharp spins, masks, but we do need to get them approved from health and safety. And I've always said we work with IPC. We need to work with IPC, MHRA, make sure that they're approved. Health and safety, occupational safety and health is a big thing in this as well. Need to be looking at design for disposal. If I can design a product that I can then say, this is really easy to dispose of. I'm actually in my office today. If I ran into my storeroom next door, I could bring you out a pediatric oxygen mask that is beautifully made from recycling, apart from it's got a little tiny spring in, which renders it unrecyclable. That was a little polypropylene spring or a little plastic spring or a little bit of elastic or something, be eminently recyclable. But because I've got a little metal spring in it, not happening. So let's design products, because we know they're going to be single use, but let's design them so we can use them efficiently, prevent infection, but then get rid of them in a more sustainable way. There is a strong will to reduce single-use plastics. We were doing so well, and then we got a bit derailed by a global pandemic. And as I've just put here, it's somewhat ironic at a global level, because we have never used so much single-use plastic certainly in the history I've been doing this, and I said 20 years, but I've been quite generous to myself. It's quite a lot longer than that. So hopefully that's given you a whistle-stop tour of waste, why it's so important, why it's hard to get it on the agenda, because it's a tiny weeny part of the budget. But for somebody like me who has been banging this door forever, thank you so much for listening to me for the last 45 minutes. Thank you.
Thanks, Anne. I hope you can hear me all right.
I can. I just need to work out to stop sharing my screen.
That's all right. Perhaps Lee will pop up one of the holding slides otherwise for us. I realised I forgot to introduce myself at the very beginning as well, so I feel a right wally, but sorry, my name's Lisa and I'm president of the Infection Prevention Society. I should have said that. So in my excitement to crack on with you, Anne, I completely forgot that.
Sorry, and I just launched in. I'm so excited.
So we've got 146 people listening to you. And I've only got 3 questions in the question box. I cannot believe that's all we've got. So start sticking some questions in, people. I've got a few, so we'll go into those. But I think the weirdest thing I've ever found disposed of incorrectly was fruitcake in a sharps bin. So that, when you say you've got 20,000 photos, it doesn't surprise me. I'm sure we could all go around our organisations and find those. So I'm just going to go to the questions we've got at the moment. I'm just going to move them up here so I can see.
Yeah, while you find those questions, the classic is, if you look at the sharps bins on the crash trolley, they've normally got celebrations or those other small chocolates, the wrappers in. So you get, because obviously there's a lot of donated boxes of wrapped chocolates, you will regularly see wrapped celebrations, roses, things like that. Yeah, indeed.
Right, so the first question we've got, Anne, is can we adapt the waste hierarchy for use in healthcare? Prevent, reuse, recycle, recovery and disposal.
But that is it, isn't it? So you can use it wherever you like. You might be manufacturing, you might be doing anything, but the hierarchy is part of the NHS strategy. It was in the last one. I think it was a triangle last time. Hopefully I managed to get my diagram in this time from DEFRA. But yes, it is absolutely adaptable to anything you do, including at home, by the way. Because I believe practices are transferable.
Thank you. So I think the next question, is something that we'll all think is a problem for us. And so Richard says, the biggest challenge I have is explaining the difference between orange and tiger bags, as without screening every patient, we cannot guarantee what is going into the tiger bag is non-infectious. Is there a way I can explain this to get my colleagues on board?
Yes. I would go down the route of, from an infection prevention perspective, I am guilty until I'm proven innocent. From a waste management perspective, I am innocent until proven guilty. So if I rock up in A&E and I've got vomiting and diarrhea, you're probably going to suspect, unless I'm super drunk, unlikely, then I've probably got some sort of infection. If I'm going to test for an infection because somebody has turned up with this really manky wound, they've probably got an infection. So if you are clinically going, am I going to test for infection? Am I going to prescribe antibiotics? They've probably got an infection. If I turn up with a broken ankle because I've just been ice skating or whatever, chances are I haven't. So you are going to treat me differently if you think I've got an infection anyway, aren't you? Not from an IPC perspective, but you're going to stick me in a corner. If I'm turning up covered in spots, you're not going to put me in the middle of A&E, are you? You're going to go, would you like to go to my end room, Peter? I'll just usher you over here. So from a waste management perspective, I am innocent. If you put the waste in the bin as an IPC professional and say, people put your waste in the bin, and then that person later turns out to have an infection, it doesn't matter. At the time, you didn't know.
Okay.
Also, you've got that source pathway receptor. So you should not be having people doing it. Once you've put it in the bin, you've put it in the bin. Transfer this to your kitchen waste. You don't say, oh, I've got a piece of mouldy cheese here. Oh, I've got a piece of ham that's all green and furry. Probably not going to eat it because it's going to make me sick. You don't get a clinical waste bag for that, do you? You put it in the bin and it goes out with the other wastes. We've got to be realistic. And I will say that if I have to do a bag split, well, I do lots of them. My worst nightmare is the black bag. I hate it with a passion. I'll split clinical waste bags and tiger bags to the cows to the bone. Not a problem, because I know actually most of it's going to be clean packaging. Even from theatres where you've got some of the good layup areas, but I still get, even your theatre waste isn't that scary. But in terms of infection, yes, they might have an infection, but unless you know or reliably believe that the waste contains pathogens or their toxins and they're viable, it's an offensive waste.
So, I mean, that's really tricky. We've got, as you said, 1.5 million employees to train is phenomenal.
Yeah, but they're not all clinical, are they?
No, they're not. But I think, and Leonora's sort of saying, thanks for the great talk. Can you give us 3 top tips to improve segregation of waste? So that's probably what we're all asking.
3 top tips. I didn't even want to do that, dear. 3 top tips. What is it? Is it clean packaging? So I think even before you start, 50% of what you generate should be, at least 50% should be in your domestic waste streams. But we have or recycling, we have so many areas that are so nervous of putting domestic and recycling into those clinical areas, that's how we end up with a lot of stuff in the wrong place. Right bins, right place, right time. So if I'm in theatres, for instance, I want my yellow bin by my patient's head because that's where I'm getting all my pharmaceuticals, whereas I might want other stuff down the other end, depending on what's going on. So right bin, right place, right time. It is education. There are some more training courses coming out. Speak to your waste manager, because you work with the waste managers. I'm always telling waste managers to work with IPC, but if this is my plea, work with your waste manager because they have an obligation to support you to segregate. I need another one, don't I? Read the HTM. Yes.
Read the HTM. But I guess which sort of fits in with what the answer to that is Lisa Redmond saying, how can we influence the HBNs in the States to plans to design waste segregation into healthcare premises? Because, you know, we places are small, we haven't got space for additional bins, etc. And how do we sort of move forward? We're having a new theatre build here in Oxford, and one of the things I said, let's think about how we're going to manage waste because it's getting more and more complicated. So
I don't think it has, to be perfectly honest. We've not changed, and the new HTM will not change any of the segregation other than say do it better. We've not changed any bin colours. We've had nothing new in since 2010. That's when we had the red and the blue introduced, pharmaceutical and anatomical. So we're not necessarily adding extra bins. What we're doing is replacing in some cases. So if I've got a general ward with side rooms on, I would expect, hypothetically, we've got a nice general ward, maybe 4-bedded bay with 2 side rooms, and my side rooms are, I've got people that are neutropenic and I've got people I'm actually protecting from everybody else rather than they've got an infection. Most of my waste is going to be offensive waste from there, unless it's pharmaceutically contaminated. In which case, I would have my infectious waste bin in my dirty utility, because I don't want infectious waste by my poorly patients anyway. I like to keep it out of there. If it's heavy, wet and smelly, so in care of the older person, I don't want it in the ward area anyway, so get that out. Keep it, your dirty utility, I don't care if that smells, to be honest, because that's where I want all the horrible smelly stuff. Don't want it in the ward environment. So actually you should have as little as possible. And that's where the taking your waste bag, and I don't want to, there's a trade name out there, but taking a receptacle to collect the waste is the best thing you can do. The key here is to not take an infectious clinical waste bag and go, actually, that was just a catheter change. There was no infection. It looked really quite nice and clean. You can't downscale it. Once you put it in an orange bag, it can't get. So if you've got something in tigers, you can take a tiger bag, for instance, and go, or take two, because you want to capture all your packaging as well. So take something to cap the packaging, something to catch your non-infectious waste. If suddenly you take that catheter out, I use catheters, and you go, oh, don't like that, either look, smell, whatever. You can take your tiger bag and put it into an orange bag. What you can't do is take your orange bag and put it in a tiger. You can only go up, you can't come down.
Okay.
So, but it is about getting that packaging out. I reckon if I came right tomorrow and I waved my magic wand, tonight at midnight, I waved my magic wand, say, take all the packaging and hand washing paper towels out of your offensive waste stream and your orange bag stream. I'm leaving yellow for now. I reckon we cut that bill by 30% overnight.
Okay, that's staggering. So there's, I'm just going to combine.
No, I can see the number, but I better look at this.
What? Look, you can't. Don't.
I haven't looked at. I don't open that screen because my system's so flaky at the moment. I'm just going to stay on screen.
It's fine. It's fine. So I'm just going to try and combine this question because they're sort of similar. So Sue Daly's asking about disposing of pharmacy glass waste is confusing, and then somebody else is saying about could you clarify how to use blue lidded medicine boxes, should be open, partially used. So a little bit about disposal of pharmaceuticals, I think then. Right.
So pharmaceuticals, the blue stream is called 180109. It's a non-hazardous stream, and that should contain part-use blister strips, full blister strips. It's got to have something in its packaging, so you can't put loose stuff in, you can't put loose tablets and things in. So it's for those pharmaceutical waste that I would only expect to see it in a clean utility. I wouldn't expect necessarily to see it in the dirty utility. So it's in your prep room. So it's for those partial things that you've used. So it's a non-hazardous stream, no blood, no body fluids, no sharps, and that goes as a non-hazardous waste stream. Used in the main pharmacy all the time. So for expired, patients are coming with patients with the pods, with the patient's own drugs, can't use them because you've suddenly changed your prescription. Again, they're suitable for that blue stream. Does that sort of answer it? So where was Sue's bit as well? Hi, Sue, by the way.
Sue was just saying that pharmacy glass waste confuses people because glass is recyclable, but not when used for drugs.
Right, you can't rinse. So the rinsing is that's from Water UK. So Water UK is the sewage undertaker for the UK, and they're split into regions. So it's Scotland, Wales, Northern Ireland. If you're in the North, you have to utilities, Thames, all those. So they don't want you to rinse bottles. Now you might be in rural Derbyshire and put half a bottle of Calpol down the sink and nothing bad's going to happen. But if you're in an environment, particularly in central London, and we know historically people used to squirt just a few mil of a CD, just another few mil of a CD. When you add that up, we were getting detectable levels of a range of pharmaceuticals, including contraceptive drugs, some antipsychotropic drugs, some recreational drugs, but they are at detectable levels in the watercourse. And if every ICU nurse squirts 5 mil of, I'll just pop a bit of morphine down it because they're saving me doing anything else with it. And I know it's unrecoverable, which is what the controlled drugs regs say. It starts to add up. So we have to be really conscious that we cannot rinse pharmaceuticals down the drain because the water treatment plants don't cope with them particularly well either.
Okay, right, I'm going to crack on because there's quite a few more. Clive Spooner says, are you expecting any significant changes in the HTM being announced next week? Oh, maybe that's a giveaway.
It is, and I'm super excited. I'm only presenting on the technical, you'll be pleased to know, and that hasn't really changed because the law hasn't changed. But what it has done is the NHS has massively bolstered the environmental sustainability side. They have bolstered the contract management side. They have put those they've written that 2060 2020-60, they've written that into guidance. The key here, and I think, and I know I'm short of time, but humor me for a minute, the waste management companies, the waste contractors have HTMO 701 written into their permit. So you may go, it's only guidance. It's not only guidance. In effect, it is written into legislation, because the environmental permitting legislations support the writing of the permits, and the permits refer to HTMO 701. So if that tells you to, if HTMO 701 tells you to segregate, then you cannot send your waste unsegregated to your waste management companies and not break the law.
Cool. Fab. Susan says, refresh my memory over giving set disposal, including blood. Many thanks.
Yellow, if it's got pharmaceutical added, if there's no liquid, and you've not got, if spikes in bags can still go in the offensive waste stream. If they're just glucose, saline or Hartmann's, any pharmaceutical, they go straight into a yellow lidded bin.
How do we get health workers to segregate? Most people just see a bin and probably don't notice the colour of the bag.
Education, cultural change, charge them. It's got to be down to education. And, you know, everybody knows, I mean, everybody on this call knows exactly what they should be doing. I think what I've tried to bring to you today is why we should be doing it. And I'm not only just looking at the legislation, I'm actually looking at the global picture, the bigger picture. On the 28th of July, 2022, we ran out of planet. We used all the resources that the Earth has to give us by the 28th of July, 2022, for 2022. My hope is this year, we can actually stretch it out to August, possibly. So we were using 1.3 planets per year. We're now down to just under 1.5. We don't have 1.5 planets. We've got one. And we're killing it. That's why I'm doing this.
Yeah.
Next.
What to say now. If you could overhaul the waste management system for the NHS, what would be your first change? And how would you like to see waste management change in the next 10 years?
Nice.
I think this will be our last question. This is a nice one to end on.
It's lovely. What would I do? I'd start with segregation. I'd start with procurement. I would make sure you have what you need to do your job. You don't have extra stuff. I would also, and this is really contentious, and I apologise to anybody that sells anything, I would also make sure we weren't in a situation of the tail wagging the dog. Because I see so many products, I see so many sexy salesmen coming in and flogging this, that and the other and doing all their, you know, jazz hands and everything. And you get all this really nice stuff that's bought by procurement, but actually you get it there and you go, I don't like that. This doesn't feel nice. I don't like that. I don't like this. I'd also make sure that people are taught at university. I'd make sure doctors were taught. I'd make sure healthcare assistants, a lot of them are in university now. I'd make sure we had this brought through education. So when they come to you as clinicians, regardless of what level they join you at, they all know how to segregate waste and they all think it's important, rather than, oh, I'm too important saving lives, which is, I see it in the list. You know, you see the F1s come in and you talk to them about waste and like, possibly far too busy, don't, you know, talk to the hand. No, get it, you know, if we teach them from the beginning, we'll all know the same thing. The rules haven't changed since 2012. And that's when well, they haven't really changed since 2006. But in 2012, we got, I say we, I was part of it. We got the offensive waste stream legally defined. And it is waste that contains body fluid secretions and excretions. So everybody goes, it's got a bit of blood on it. Can I make it clinical? Can I make it, I need to treat it? No, you don't. So that's what I do. I'd start with education. I can see if we got this right, if we really got this right, a lot of the clinical waste management companies wouldn't exist.
Mm-hmm.
We are supporting them by giving them what they want, easy to treat, hardly hazardous because it's so diluted, and dilution is not a solution, by the way. So diluted that actually our hazardous waste isn't actually that hazardous. It should be horrible. It should be horrible. It should be scary. It should be hazardous. And then it will be treated with respect it should have. How will I do it? I don't know. I will though.
Somehow I don't doubt you. And I think that's been a fabulous hour. Thank you so much. There's a lot of questions that we didn't get to, but
Oh, sorry. If
if
you want
we-
to send me some by email.
I thought you might say that. We can just answer a few the ones that we didn't get around to. So thank you very much, and thank you all for
Thank you for
joining
listening
us.
to me.
And we'll hope to bring you another webinar as soon as we can. So have a good evening, everyone. Thank you.
Hopefully
Goodbye.
not quite as intense as that one. Thank you very much.
Bye
Cheers.
all.
Bye. Bye-bye.